Welcome back, clinical problem solvers, to the amazing Teaching Points Recap VMR. I'm Rahul Puttabatani, one of the CP Solus Academy members. Today, I'm very honored and very excited to invite three of our fantastic dedicated Academy members to do the teaching points for the month of May, sorry, for the month of April. And we have Simi here and one of the Academy members and Heman and Patricia. And so first, Heman wants to go ahead first. Heman, do you want to unmute and introduce yourself to the audience? And let's get started with your fantastic case.
Hi, I'm Heemun. I'm ING from Korea, and I'm living in Utah right now. And yeah, let's try. Here, can you guys see it? Okay, so my teaching point recap case date was April 25th, 2025, and presenter was Nicola, and case discussant were Ravi and Deborah. Okay, and Okay, so before I start the case, I want you to know the two main abnormalities you notice and identify the subcategory that each one falls under. Okay? Okay, let's start. 70-year-old male with a swollen, bruised, and excruciating painful right upper thigh occurring one day after twisting his ankle while hiking. Vital sign temperature 37.4 Celsius, heart rate was 30, BP was 103/67, respiratory rate was 18, SpO2 was 97%, MSK, severely swollen, bruised right thigh, weak femoral pulse, absent popliteal and foot pulses, hemoglobin 8.9, platelet, PTT within normal limit, CK 15,000, LDH 800, and the AST, ALT 400 and 300, and ALP was 70, and potassium was 8.8. HO3 is 15, and creatine 2.1, and BUN was 38. Yes, so Simi, yeah, that's really excellent. Platelet and the hemoglobin is very important, and that is the most important thing that I want to cover. But before that, let's look at the heart rate. What do you think of heart rate 30? Yeah, heart rate 30, is it abnormal, right? Of course, it's a really abnormal, right? So I'm going to put Dude, how come it's not working? Okay, so bradycardia 30 is because of the potassium was 8.8, hyperkalemia, and then CK is 15,000, and LDH was 800. So we can think about weak, swollen, bruised, and experiencing painful right upper thigh, and with a distal absent popliteal foot first, we could think of a compartment syndrome, and compartment syndrome is causing rhabdomyolysis, right? So when you have a muscle damage, what kind of thing is released? Potassium and LDH. And here AST is also, you can release it from the muscle damage, muscle enzyme. And also when you release myoglobin, it can damage creatine and BUN, acute kidney injury. So with acute kidney injury, and also it can release lactate, so causing the metabolic acidosis. So with the metabolic acidosis, acute kidney injury, and the potassium is getting worse and making bradycardia worse. So this was one abnormality that you had to think. And the next one that we consider was hemoglobin, right? Hemoglobin 8.5, and somehow hemoglobin 8.9, and hemoglobin 8.9, and then also Bruce died, and false festomy was done because the patient was having compartment syndrome, and the patient was having keep bleeding. So we have to suspect significant internal hemorrhage, like because the thigh can hold more than 1 liter of blood. But this patient platelet count was normal and PTT was normal. So what could we think? Yeah, so what could we think about when the platelet count and PTT are coagulation is normal? What can we think about it? So bleeding with a normal? Yes. Someone answer? Yeah, go ahead. Yeah, so bleeding with a normal platelet coagulation, we could think about quality platelet dysfunction like aspirin, uremia, and coagulation defect, factor 13 deficiency, hyperviscosity, hypothermia, and a von Willebrand factor like mucocutaneous bleeding, right? Gum bleeding or menorrhagia, or vascular issues like vasculitis, amyloidosis, and scurvy, and connective tissue disorders. And also focal bleeding, vascular like aneurysm, AVM, and varicose varus and neovascularization. We can detect this from CT angio or MRI. And so we did a VWF, and the antigen activity was normal, and the vitamin C was normal. Platelet aggregation study was normal. So what is next? What coagulation factor deficiency or inhibitor can present with the normal platelet count, PT and APT? And this person had muscle hematoma, and it was deep bleeding, not mucocutaneous bleeding. And also after surgery, they had a delayed bleeding. What is the factor that you can think of? Okay, factor 8. Oh, no, not factor 8, but a very good guess. Factor 13, inhibitor or factor 13 deficiency. So factor 2, 5, 7, 8, 9, 10, 11, 12, all normal activities. So why is factor 13? PTT is normal, but why is it like, and also why is it like delayed bleeding? So if you look at the coagulation level, like if you look at hemostasis step, you will understand. So let's dive into the hemostasis journey. Oh, okay, just a moment. Okay, so when it's a bleeding, there is a vasoconstriction is the first step, and then temporary platelet plug, a primary hemostasis, and then third is coagulation cascade. So you go APTT. I memorize as a play table tennis, so it's the inside intrinsic 12, 11, 9, and 8, and play tennis outside, so it's extrinsic 7, and then common pathway is starting from 10 and 5, and prothrombin is 2 to thrombin to 2A. So both of these APTT and PT is occurring here, okay? But then and then fibrinogen is 1, and the fibrin 1A, including all this, is a pathway. So affected by APTT here, PT here, and both here. However, if you look at the 13, and 13, factor 13 is outside this pathway. And what is function? Function is fibrillin is making cross-linked fibrillin and fibrillin stabilization. So if you look at the step, the 13 is the last step, and also this one is not affected by PTT and PT, and that's why it's a delayed bleeding is occurring especially in the focal, like after surgery. So it's occurring that. So how can we diagnose this 13? Because PTT is normal, right? Can we use mixing study? So like if you use mixing study, the problem is that you add a plasma normal coagulation factor, and you have to check whether it's a correct PT or not correct, right? But in the beginning, it is already normal. So we have to use another way. What is factor 13 is very unique. You guys will be surprised. So factor 13 has a very unique character. We use ammonia release assay. Factor 13 is active by thrombin, and calcium 2 plus becomes factor 13A, which is a transglutaminase enzyme. It's a cross-linked glutamine and lies on fibrin. It releases ammonia. So more ammonia and higher factor 13 activities. So you can find that whether factor 13 has a problem, we can check the ammonia, right? So now we can find the problem, but next step is it deficiency or inhibitor? So next step, we need a mixing study. So mixing study with so you add a patient plasma with a normal plasma, and then again, you have to check the ammonia activity. So if it is correct with ammonia activity, then it was factor 13 deficiency. And if it's not correct, it's a factor 13 inhibitor. And then final step is Bethesda assay, which confirms and quantifies inhibitor titer against factor 13. So this is the final slide and understanding of factor 13 deficiency. So if it is the normal platelet count and coagulation factor is coagulation panel is normal, and it is deep bleeding and delayed bleeding, then don't forget about factor 13. Thank you for listening, and this was my reference, and this was my slide. Yeah,
First of
that's
all,
it.
thank you so much, Himun, for touching on some of the rarest syndrome that we have to know it based on the related with clinical laboratory. And personally, this is the first time I'm understanding about factor 13 deficiency and how it can cause delayed bleeding. And really, thank you so much. And if anybody has any questions, you can unmute yourself or you can put it in the chat. I think audience are mesmerized with your presentation, and I feel they don't have, and you did not give any space for them, to raise any question. That was fantastic presentation, even. And next we have our other dedicated and academy member, Patricia, who's gonna touch on other important case. And Patricia, do you want to unmute and introduce yourself to audience?
Okay. Hello, everyone. I'm Patricia, IMG from Cameroon. Right now, I'm in Cameroon. I'm really excited to present you a case. Yes, let me screen. Okay. Okay. All right. So I was saying, I'm really excited to present you a case that was discussed on April 11 by Shamin and Rabi. The case was presented by Zachariah. So without further ado, let's start it. The case started with a 30-year-old female with a new onset of hemoptysis dyspnea over the past 2 months with facial puffiness, orthopnea, epistaxis, and weight loss. Our discussion focused on the bleeding, like with the hemoptysis and the epistaxis. And we also had a focus on the heart failure symptom and the overall inflammation. So to continue, past medical history, she did not have any sign of hypertension, any history of diabetes or cardiovascular disease. On physical exam, her blood pressure was elevated at 175 over 105. Her respiratory rate was at 22. Her heart rate was 115. She had increased GVD, S1, S2 gallop, lower bilateral pitting edema, and mild respiratory distress. So at that point, the focus of our discussion was to eliminate important conditions like cardiogenic shock or high output heart failure. We had that teaching point about heart failure plus tachycardia, especially sinus tachycardia and low blood pressure. It's important for us to eliminate cardiogenic shock. And heart failure plus tachycardia and high blood pressure, we need to think about high output heart failure or aortic regurgitation. So at this point, we can ask for an EKG to make sure that we are in sinus tachycardia, not maybe atrial fibrillation, and we can ask for an echocardiogram to eliminate any valvular disorder. So we had more information, more data about our case, like the lab were relevant, like we had an anemia at 7.9, creatinine was elevated at 15.6, BUN at 121, and CRP was elevated at 116. Reanalysis was relevant for proteinuria, hematuria, no white blood cell, no red blood cell. So to summarize, at this point, we had symptom of heart failure, we had sinus tachycardia, hypertension, bleeding with epistaxis, and kidney injury. So my discussion today will be focused more on the kidney injury because we started to think about glomerulonephritis. So what is glomerulonephritis? Is a number term applying to condition that cause inflammation of the glomeruli. And we all know that the glomeruli is the filtration unit of the kidney. So we had three main types, depending of the immunofluorescence staining result. So we have the post-immune, the immune complex, and the anti-GBM. Post-immune is characterized by a minimal to zero immunofluorescence staining. Immune complex, we can see granular deposit, and anti-GBM, we see a linear distribution. So this is a nice schema from CP solver where we have those different subtype and the subtype have other subtype. So 60% of the time we can find post-immune glomerulonephritis. It can be NCA positive, 80% of the time is NCA positive, but you can also have like NCA negative post-immune glomerulonephritis. Immune complex can be further divided into normal complement or low complement, and anti-GBM is usually good pasture. So to come back to the immune complex and glomerulonephritis, as I was saying, is further divided into normal complement where we have like IgA nephropathy or fibrillary glomerulonephritis, and low complement, we can further divide it in infection, autoimmune, or cancer. So when to suspect glomerulonephritis? So we need to have like like some sign like nephritic syndrome. And I don't know for you guys, but for me, it was important to remember that nephritic syndrome is not a diagnostic, it's a constellation of symptoms that form nephrotic syndrome. So in that bucket, like that big range of symptoms, we have AKI, we have hematuria, hypertension, and proteinuria, like proteinuria less than 3.5 gram, because when we exceed 3.5, we are already in the nephrotic syndrome range. So, and it needs to be like glomerular hematuria. What is glomerular hematuria is when you see dysmorphic red blood cell, like from the glomeruli, when the red blood cell pass through the damaged glomeruli at the level of the nephron, it becomes dysmorphic. And you have red blood cell cast from that form in the loop of Henle. You can also have pyorrhea or systemic inflammation. So this is another schema on how to diagnose glomerulonephritis. So you need to have proteinuria, and not only proteinuria, because protein come on with different size. You need to also have like albuminuria, which are bigger protein, you know. So you have proteinuria, you have hematuria. You need to exclude alternate causes of hematuria, like maybe a mass that you will find on an ultrasound, or you need to exclude other causes of AKI, like pre-renal causes. And when you do the urine smear, you need to see dysmorphic red blood cell or red blood cell cast, and the biopsy is the gold standard. So to summarize the presentation of glomerulonephritis, On physical exam, you can suspect glomerulonephritis if you have like a patient with hypertension, fluid retention with facial puffness, pulmonary edema, if a patient have like nephritic syndrome, oliguria, or systemic inflammation. Imaging and lab, the urinary analysis is important. On the urinary analysis, you will see the proteinuria or albuminuria. You need to have like a microscopic of the urine sediment where you can see the hematuria, like which type of hematuria is it? Is it micro? And if it's microscopic, is it red blood cell count? Is it dysmorphic red blood cell? And you can also you need to do immunofluorescence to know the type and pattern of glomerulonephritis. And you can also do electron microscopy or light chain. But as I was saying, the gold standard for glomerulonephritis is the kidney biopsy. So let's say you suspect glomerulonephritis, you do the immunofluorescence, you have your UA already, you have your microscopy. What else can you do? What else can you do? You can also do like ANCA serology because to know in which bucket you have. Remember, we have post-immune, you have immune complex, and you have anti-GBM. So in the post-immune, you can do ANCA serology. For the anti-GBM, you need to do anti-GBM serology. You need to do ANA serology, like to exclude maybe to rule in or rule out lupus. You need to have complement level and viral serology. It's important to do that workup because most of the glomerulonephritis diseases, the treatment depend on the underlying etiology. For example, for anti-GBM glomerulonephritis, the treatment is plasma exchange. For ANCA-associated vasculitis, the treatment is usually steroid, cyclophosphamide. If we are in the bucket of the low complement glomerulonephritis, under the bucket autoimmune glomerulonephritis, we need to think about lupus, and lupus also has its own treatment. So having that workup is important. So to come back to our case, in our case, our patient, we started to, as I was saying, we started to think about like glomerulonephritis because our patient has sign of nephritic syndrome. She was hypertensive. She had hematuria, but when we did the workup, like anti-GBM, ANCA serology, viral serology, it was all normal. Like she had normal complement level, and every single test done for etiology workup was negative. So we started to go away from the usual part of glomerulonephritis and think about mimickers. And those mimickers is usually those diseases which cause hematuria without inflammation. In that bucket, we have the treatment causes, but we can have more like TMA, thrombotic microangiopathy, malignant hypertension, anticoagulant-related nephropathy, especially for those who are on Coumadin, or scleroderma can also be in that bucket. So in our discussion, our patient had like severe malignant hypertensive nephropathy. But the case was like, so we ended our case here. They didn't have like telltale sign of glomerulonephritis, but it was all caused by severe hypertension, and she has underlying tuberculosis. So thank you. That will be all for me.
Thank you so much, Patricia. And you really covered the challenging part of the kidney disease, which is glomerulonephritis, and how to diagnose GN and what are the next steps, and how difficult sometimes it is to, we have a correlation of the TMA processes and malignant hypertension as seen in this case. And fantastic presentation. And if audience has any question, you can put it in the chat box. And look, and audience are bombarding with all fantastic texts. It really shows your commitment and hard work to the reasoning and passion for the medicine, Patricia. Very, very proud of you. I think again, you nailed it again. I think audience don't have any questions. And yeah, now we can move on to our fantastic and last case presenter, Simi. And Simi, you want to unmute and introduce yourself and share your screen?
Hello, friends. Thank you, everyone, for joining and great presentations, Nemo. I liked your colorful interpretation. And Patricia, I loved how you told about all the tests for glomerulonephritis and separately for treatment and everything. It was just awesome. And I'll start sharing my screen and I'll summarize a case from 6th of April today. And I hope you guys get to learn a little. Mm. So can you guys see my screen? Okay, so let's get started. It was a case presented by Elena and discussants were Rabi and Ibrahim. And today we will talk about approach to altered mental status and talk more about one of the causes. So let's get started. So the patient presented with altered mental status and somnolence. And whenever we have altered mental status, we think about the causes of altered mental status as well as the consequences of altered mental status. And for the causes, we have this wonderful schema of MIST. And we think about metabolic causes, in which we think about electrolyte abnormalities, CO2 retention, liver dysfunction, and also hypoglycemia is something worth considering because often low sugar level presents with altered mental status. And we also think about ammonia level in metabolic causes. We can think about infections as well, whether the patient has an intracranial infection or extracranial infection, such as pneumonia or UTI. Then we come to structural causes, such as subdural hemorrhage, and we can always think about toxins, such as opioids or ethanol withdrawal. And as for consequences of altered mental status, we should always think about airway, breathing, and circulation. These are some things that should be focused on when caring for someone with altered mental status. And now I'll give you some more information about this case. So as for the history of presenting illness, the patient was sleepy, was able to answer questions, but was disoriented to place and time. And also the patient had melena present. As for the past medical history, the patient had a history of cirrhosis, ileal conduit after bladder cancer, and also chronic kidney disease. And patient was on aspirin, warfarin, clopidogrel after stent placement. Vitals were normal and asterixis was present. So what was worrisome for this patient was that we were thinking about altered mental status, and patient had history of cirrhosis and chronic kidney disease and ileal conduit as well. And patient was on 3 medications, which could increase the risk of bleeding in this patient. And as for asterixis, we were thinking whether it is related to kidney or liver. And I would like to ask you guys whether anyone wants to unmute or share in the chat that what labs do you want at this point for this patient? And then I'll just bring some lab data for you. Yeah, great thoughts. So Bushra mentioned about uremia, ammonia, intracerebral hemorrhage, and yes, you guys are so on point. And also Hans mentioned about liver cirrhosis and ileal conduit, which are worrisome. So you guys are so on point. And now I'll mention some labs. So as for what test to do, we also have to scan mnemonic. We can think about sugar, CT scan of the head, altered ABGs, and also airway and narcotics for someone with altered mental status. So what test did we have in this patient? We had a low hemoglobin here in this patient. MCV was normal, CT head was normal, electrolytes were normal, and ammonia level was found to be elevated. And alkaline phosphatase was elevated, GGT was high, albumin was low, INR and PTT was high, and ultrasound shows cirrhosis of liver. So we were thinking when we had this low hemoglobin, we were thinking maybe, and also we had low hemoglobin and INR and PTT were high. So we were concerned that maybe this patient has some sort of bleed because as I have already mentioned, the patient was on 3 medications, 3 anticoagulants as well. Here we saw in this slide, he was on aspirin, warfarin, clopidogrel. So we were concerned about the medication interaction here. And then we had elevated ammonia level. And now for the next rest of the teaching recap, I'll focus more on hyperammonemia, what can cause hyperammonemia, and how ammonia is metabolized in the body. So let's get started. So how is ammonia metabolized in the body? In the body, we have protein, which get converted to amino acids. Amino acids get converted to ammonia. Ammonia enters liver, and by urea cycle, it gets converted to urea, which goes to kidney and is excreted in urine. And if any of these steps gets overwhelmed, or there is a problem at any of these steps, it can result in hyperammonemia. So what happens at the level of intestine? For instance, if we see this picture as intestine, in the intestine, protein is broken down by bacteria into ammonia. And anything that causes increased protein in the intestine can cause increased ammonia production. So what can cause increased protein in the intestine? Either high protein load, as in total parenteral nutrition or in GI bleed, or high protein breakdown in conditions such as starvation, exercise, seizure, or trauma. So these causes are worth considering. And in our patient, we had GI bleed, which was contributing to hyperammonemia because when we have GI bleed, the RBCs have a high content of protein and it gets metabolized by bacteria and gets converted to ammonia. Now we can also have hyperammonemia due to urea cycle disorder. And what can go wrong in the urea cycle? Either cirrhosis can affect the ability of the urea cycle to metabolize urea, or drugs such as valproate, carbamazepine, and ribavirin can affect urea cycle. Also, sometimes there are some errors in metabolism, such as OTC deficiency or ornithine transcarbamylase deficiency, which affects the urea cycle. And in this patient, cirrhosis was the contributing factor. So there is another cause of hyperammonemia as well, that is due to liver bypass. Sometimes the liver gets bypassed and so urea cycle cannot work. It can be seen in portosystemic shunts as in cirrhosis. TIPS is a procedure where portal hypertension is treated and we bypass the liver, resulting in elevated ammonia level. And ammonia cannot be metabolized by urea cycle in the liver. And sometimes patients have congenital defects and liver is somehow bypassed. Now, what happens next? After liver, the urea cycle converts ammonia to urea. Urea enters the kidney. And what can go wrong at the level of kidney? Either kidney is not working as a form of chronic kidney disease. It can impair urea excretion, or in kidney, we can have urease positive organisms, which convert urea back to ammonia. And urease positive organisms include Proteus, Klebsiella, E. coli. And other causes of hyperammonemia include ileal conduit, organ transplant, and myeloma. And this patient also had ileal conduit because after the patient had bladder cancer, it was treated with ileal conduit. And what exactly is ileal conduit? In ileal conduit, the patient's bladder gets replaced by ileum. And when urea comes into the ileum, bacteria convert urea to ammonia. And in the ileum, there is increased absorption of ammonia, which can result in hyperammonemia in the patients. So what was the final diagnosis in this patient? The patient had hepatic encephalopathy, which was due to elevated ammonia level. And the contributing factors for GI bleed, as patient was on multiple anticoagulants, and ileal conduit was also contributing, and the patient's underlying kidney and liver disease were also contributing. And now I just have a summary for you. So the take-home points for this session. So what happens in the intestine? The protein gets converted by bacteria to ammonia. Ammonia goes into urea cycle, gets converted to BUN, which is metabolized by kidney and removed from the body in urine. But if anything goes wrong at any of these steps where they get overwhelmed, this can result in hyperammonemia. And in our patient, we had GI bleed, which was causing increased protein production and hence increased ammonia production. We also had portosystemic shunt, such as in cirrhosis. We had urea cycle disorder due to cirrhosis. Patient's kidney was not functioning well. And we also had another contributing factor, which was ileal conduit. And thank you so much, everyone, for joining. And I hope you got to learn a little from this session. And I would love to answer any questions or if you have any reflections.
Thank you so much, Simi, for the wonderful presentation. To be honest, we learned a lot, not little bit. We really learned a lot, and you really touch based on the very fundamentals of hyperammonemia, and we went back to the basics of biochemistry, and you really correlated with the clinical medicine. We really love that, and we also love the your schemas and all the wonderful and colorful presentation. And thank you so much once again. If if and if anybody has any questions, you can put it in the chat. I think none of the audience has any questions today. I think you and Heman and Simi and Patricia, you guys are wonderful, and it was a very, very phenomenal, teachings within, I guess, less than 40 minutes. This is wonderful, and I'm really, really looking forward to learning from you again. And thank you so much for doing all this, and thank you so much all the audience for taking all the time and joining the session. I hope you have a great rest of the day. Thank you. Bye bye.